Yes, all right. There we are. Well, good afternoon, everyone, or good morning, depending on where you are, or good evening. Welcome to a new Global Health Round. Today, we're going to talk about a diabetes project in South Africa. And we have Nicole Fiolet in our midst to talk about her project. She is a medical doctor global health since 2021. And since then, she has worked for the Tsamba Foundation in South Africa, where next to clinical work, she has worked on various projects and overseen them, of course, such as in the improvement of breast cancer screening or cervical cancer screening. And today she will be telling us about her another project she started over there, and that's the diabetes program. And I am very curious and excited to hear about her story. And so actually, without further ado, I will give the word to Nicole so she can take it away. Let me stop my screen sharing.
Thanks, Elseline. I will start sharing. There we go. Please interrupt me if you have any questions, and otherwise I will just ramble about my passion at the moment, which is diabetes. Something that evolved. I have never really had interest in diabetes, or it was not part of our training, but it is a quite actually exciting topic to get involved in. So yeah, here I go. I am working for Tsamba Foundation. So I used to be a volunteer for 6 months. That was 4 years ago, volunteering for Tsamba Foundation. And now, since 3 years, I'm working for them. So Tsamba Foundation is an NGO that brings in volunteer health professionals from all over the world, but also from South Africa, to volunteer in Tinswalo Hospital and in the 16 surrounding clinics. We are based in South Africa, Akerhoek, next to Kruger National Park. And we work in Tinswalo Hospital that has 314 active beds. The 16 clinics drain on this hospital. The catchment area population is around 200,000, but that is from like 10 years ago. So I think it will be a bit more now. We have a high unemployment rate, 44%, and 25% of our patients are HIV positive. And then diabetes. Why this focus? As I said, it's not my passion at all, but it just happened to be a question from the hospital, actually. Can you help us with diabetes? And why? Because it is a very fast, rapidly growing problem. At the moment, they think there are 5.7 million cases in South Africa, and 50% is undiagnosed. On a population of 60 million people. 5 million people have pre-diabetes, and 90% is type 2, which is partly preventable. And it is the #1 killer of women. So when I heard that, being involved in a women's health project before, I was like, oh, let me focus on this. And the numbers were quite shocking to me. 60 to 80% die before the age of 60. And if you have amputation due to diabetes, then you have 70% die within 5 years. In South Africa, only 23% meet their glucose target, and that's including private care. So yeah, it's very low. And Tinswalo sees about 500 patients a month with diabetes, and 3,000 people are receiving treatments in the primary health clinics, the 16 surrounding the hospital. Well, this is the estimated prevalence of diabetes in the coming 15 years. So it is just a very rapid growth. And we are not there yet in this area, but we also see that there's just a lot of new patients. So yeah, I started to think, and I did try to not actually go into diabetes care because I knew it would be huge. But yeah, then together with the volunteers, I started find out what was available and what was actually the problem, and then I started to dream big. And that's what we learned during our tropenopleiding. So yeah, the PDCE cycle. During my studies, I really didn't like this, and I was like, but it does make a lot of sense. And yeah, you really have to plan and identify the problem and see what you can do and check if you have to, if you achieve what you want to achieve and adjust it. So yeah, I will, yeah, it sounds boring, but please use it in any project that you're going to do for improvement. I learned the kind of the hard way. I started with a small project, like Elseline said, especially cervical cancer screening. And that started with screening first. Thanks to Dr. Anne, I see she's also here. The hospital actually asked us to start the pap smears after COVID. We stopped screening for cervical cancer, and now we restarted it very successfully. 140 women were screened in the first month, but then 40 needed treatment, and we only had the capacity to do like 4 women a month for treatment. A cone biopsy, and most of the times it was cancelled because of seizures. So then we started to think how to treat these patients, and that's how I opened the Let's Clinic. A really excited project. I can talk an hour about it as well, but it is really nice. In the first year, we did about 150 Let's procedures, and with that, estimated 75 women had a cervical diagnosis prevented, cervical cancer diagnosis prevented, and 10 had an early stage cervical cancer. So that was a huge success. So that's why I did dare to dream big about diabetes. And this is my PDCE cycle. I just like to draw things and dream big. It was October 2023, so almost 2 years ago. And you see a lot of names. It might not make sense at all for you guys. But my dream was to open a clinic in a year time. And it just happened to be going faster than expected, actually. But now it takes a little bit more time. I wanted to have the eye clinic involved. WC is the women's clinic involved in diabetes care schools, and we do a lot of training and awareness. And of course, this whole plan changed along the way. But still, it's almost October 2023, and I can say that there is a diabetes clinic, and we are supporting 2 primary health clinics. So not 4 yet, but I'm proud. Yeah, I will show you what happened. It first started, so instead of like going for screening first and then treatment, we now wanted to have the treatment well first. So I got a team together, a hospital team, and we learned from each other. So this team, it consists of a dietitian, a nurse, a pharmacist, and a doctor, and then a patient living with type 2 diabetes that would do the education to the patients and the support for the patients. And the first few months, I think, we just sat together, we saw a few patients, and we learned from each other. And 1 year later, the team changed a little bit. It grew, and we're standing in front of the diabetes clinic. Very excited. We have 2 pharmacists now, 2 dietitians, patient educator, patient ambassador, a nurse. Sadly, we did lose the doctor, so I'm at the moment the only doctor doing the clinic. And our goal is to contribute to the South African diabetes targets. And I think for HIV, you might know it's the 90-90-90 target, or maybe they changed it now to 95-95-95. For diabetes and hypertension, it's also for the WHO, the target is 90-60-50. So 90% of the people with diabetes or hypertension needs to be diagnosed. 60% of those need to receive treatment or intervention, and 50% of those on treatment have to have a controlled disease. We are, I don't know the exact numbers, but we're definitely not there. But at least we're trying, and that's. Do you want to ask something else, Lee?
Yeah, I was wondering before when does South Africa want to achieve that target?
I think it is 2030.
Okay, so still 5
Soon.
years to go.
Yeah, that's not gonna happen, I can tell you. But maybe in our area we can achieve that. But no, the government is not really helping with that. So yeah, it for me, when I started this project, it was all about screening, catching diabetes early. And if you are then, you have to diagnose diabetes, then there must be treatment just at the primary health clinic. But if it's more complicated, then you go to the diabetes clinic. And we are there to prevent more complications. And yeah, we work together to get the complications better controlled. In our area currently, 200,000 people are living and 3,500 people are receiving treatment. And that is a 1.8% prevalence. In South Africa, it should be 9%. And that's not because I live in a very healthy area. I mean, it is different. It's very rural, so it's not like in the cities. But 1.8% prevalence is just that we are not diagnosing patients here because we don't screen. Because we went to a mall here. So yeah, it is quite rural, but we do have a mall. And in front of one of the supermarkets, we started to screen, and 40% had an abnormal glucose screening, which can be either pre-diabetes or diabetes. So that was quite shocking and emphasized to us we really need to screen and get those patients early on treatment, because most patients go undiagnosed for 10 years, and that causes complications. Yeah, so screening, but then what happened? We didn't have any glucometers or strips anymore. So yeah, we can't actually screen. This is a picture that we took because we got a glucometer donated. So then we are lucky we can check some patients, but at the moment, sadly, we can actually only test patients that have diabetes to see what their glucose is currently. So yeah, that's very sad. This was also before that all happened. We did some screening at clinics. In OPD, all patients are screened. And we went more often to the mall. And yeah, you can screen at the mall, but if it's abnormal, they have to go fasting to their local clinic. And if they don't have strips, we can't really help. We can't really screen, so that we don't really have a solution for that yet.
Nicole, this problem with the strips, is it nationwide or is it something in your area, or what's happening?
Yeah, it's province-wide. I'm working in Mpumalanga province, and that is not the most functional province of South Africa. So that is a little bit of a corruption story. Yeah, they're fighting for who can deliver, which brand can deliver to the government, and it's also just the political correct answer is that their focus is more on maternal and child health and HIV, and the budget goes to those. But I also know that the budget goes to high-placed people.
Yeah. And then Erna is asking, did you consider using urine strips so you could get an idea of glucose or urea?
Also, those are out of stock often.
Okay, so that doesn't help.
No, unfortunately. The thing is, we can think about sending blood to the lab. That is never out of stock, but it does increase our budget. Yeah, so don't want to think yet about that. I really hope that soon there are promises that the script will be available soon again.
Sorry,
so
Azim, can I ask a question?
Sure.
Yeah, my name is Richard. I'm living just next door in Mozambique. I was trying to set up a program against diabetes. Just I want to know which protocol are you using to diagnose a patient on diabetes to come to your clinic and begin treatment? Which protocol are you using?
I'm using the adult primary care protocol that is actually made for nurses. And that it pretty much says if you have a fasting glucose of above 7, you have diabetes twice.
Twice.
1 week apart,
Fasting.
twice a fasting glucose, then
fasting
you have diabetes.
Above 7. Okay.
But between 6.1 and 7, you have pre-diabetes. So even those patients we want to, that's the time to change your lifestyle.
Okay, fine. Thank you.
Yeah, and then once diagnosed, there is a lot of hesitation to actually start treatment. The treatment, the first step is immediately metformin and lifestyle change, and it's of course very difficult. But nurses even don't dare to start the metformin, and especially don't dare to increase the treatment. So that's a big lack in care as well. And if they want to start insulin, the people living here are really scared of insulin. There's a big belief that if you start insulin, you die, which is not unfair. I think we start insulin very late, so people are almost dying, and then so we have to really change that mindset. Show people what kind of needles we're using. They think it's very painful. There's a lot of misconception about insulin, and it does start with the nurses and the doctors that are also actually very hesitant to start insulin. Then when you convince someone to start insulin, people need to have a glucometer. It's really difficult to otherwise track how much insulin you have to take, especially if you want to be well controlled. You do have hypos, and they need a glucometer or a very good understanding of what a hypo is, how that feels, and that they have to eat at that moment. Yeah, they are unable to track their condition effectively if they are on insulin, and it's just very dangerous to use that. And like one of our patients said, he's living with type 1 diabetes in a very rural area here, like 35 kilometers from the hospital. Living with diabetes without a glucometer is like walking blindfolded on a highway. And that is, it almost feels for me at the moment to send patients on insulin home without strips is like that I sent them on the highway blindfolded. So it's scary. And if I knew that this would have happened, then a year ago, I wouldn't have started this program. But now we just make it work.
Nicole,
because there are...
Sorry to interrupt. I have another question from Anne. She's asking, why are the nurses actually afraid to start metformin?
Good question. Yeah. I don't know. I don't have an answer. I don't think metformin is very dangerous. It can make your stomach upset. But I think it is, even like with HIV, there's just such a hesitation to start medication and follow up. That is also, I think there's not an understanding of what an abnormal glucose is. So they only are alarmed above 11. They know something with 11 that's dangerous, but between 7 and 11, they have no clue that it is something that you can be diagnosed diabetes. So I think that's the reason that they don't. But why they don't increase the metformin and then the glimepiride, I don't know. That's a good one to find out.
Yeah, maybe to have the conversation with the nurses and find out indeed. Yeah.
So there's a lot that we can do. And that's what we do with the diabetes team. It's a holistic approach. And we try to standardize the care. So nurses can follow the protocols. The doctors here in the hospital can all follow the same standardized protocol. But if they still fail to treat that patient, we take our time to see why there's a treatment failure. And that can be as silly as people are injecting with an empty syringe or not the right amount. Or they inject, often they inject too deep, so in the muscle, so that can influence a lot. So yeah, we found out a lot of things that happened just by taking time for the patient and talking to them. So we pretty much take an hour per patient. But I did work on standardized protocols. So yeah, this is from the protocols from the adult primary care. So it's very basic because we only have very basic diabetes care. But yeah, following this protocol, you can stabilize a lot of patients. Then I started to work with the whole hospital because everywhere in every ward there is diabetes. So for instance, in the surgical ward, if we have a surgeon, I worked on a wound care protocol. Actually, it's one of the MD Global Health that came here as a volunteer that made a wound care protocol. So we're using that. Of course, in a medical ward, we see a lot of DKA. Something in the Netherlands, you don't see DKA often in type 2s, but in the Black population, you do see DKA more often in type 2s. And we have to manage that without ICU things now and drip, or we do have drips, but no pumps or fancy stuff. So that is quite, we do have sometimes a gas machine. 50% of the times we have a gas machine, but otherwise it is very basic care, but you can still manage it then. With the eye clinic, we work on screening for diabetic retinopathy, and that's not because we can treat it, but it is another screening tool to tell patients how much damage they already have for their diabetes. And to emphasize, yeah, we can't treat your diabetic retinopathy other than controlling your glucose. We work in OPD for screening, and they use their standardized protocol as well. Casualty, of course, when the DKA or HHS comes in. And with the obstetric department, we worked on another MD Global Health actually worked on the gestational diabetes protocol and screening, and that all those patients come for follow-up to the diabetes clinic. Yeah, like I said, who are we learning from?
Can I ask a question on the?
Yeah, sure.
On the previous, on the how you work with the air clinic, it's a one way or two ways. I mean, are you sending patients to them? Also, sometimes they send a lot of patients to you who are diabetics. They have a problem of vision, something like that. Because me, I used to have a lot of patients from ear doctors, from ophthalmologists. Isn't it about your clinic also?
Yeah, no, it's a two-way service indeed. Yeah, they see diabetic retinopathy and then they send a patient with uncontrolled glucose to me.
Exactly.
Yeah, no, we work together definitely.
Okay.
And that's with all departments. I mean, if you're discharged from the medical ward, it means you're very uncontrolled and you come to the diabetes clinic. See how we can help and follow up to prevent another admission.
Okay, good. Thank you.
Sure. Yeah, so I learned a lot from a CDE course. That's a private company that offered us actually free courses for every member of the team. So we all did the same course. I learned from visiting volunteers, so I'm always eager to get diabetes specialist or internal medicine specialist, or next week we get a diabetes nurse that visits, so I learned from them. But other than that, there's also, it's kind of very easy standardized protocols, so it's not that complicated if you don't have all the fancy stuff that they have in private. Yeah, and then I expanded services, including a pediatrician that wanted to take care of the kids. We have 18 children in this area with type 1. And yeah, he came a few times and now he doesn't come anymore. So now I am stuck with all those kids. But again, it's really actually quite fun to help them. Then we also partner with traditional healers and the community health workers. Traditional healers mainly because 80% of our patients in the hospital go after a consultation to the traditional healer and ask, what to do. And traditional healers can say that they have to stop insulin because it's not working, or they are bewitched and they should not go to hospital. But there are definitely a lot of traditional healers that actually want to learn more about diabetes and how they can help, what kind of teas they can give to the patients without harming them. So we try to focus on those traditional healers. And the community health workers, they are linked to the clinics, and we give them education about, it was first about screening, and now it's more about education about healthy living, actually. So this is a group of community health workers, and they love it when you give them a certificate. I'm very proud of it, and it is a very fun, was a very fun training day. And these are the traditional healers that we did a training for. And then we are happy to have a diabetes clinic with a dedicated patient waiting area. And everyone is welcome every Wednesday at 9 a.m. to get the education about diabetes. So yeah, this is from, I think, 2 months ago, just a few patients, but now, like this morning, we had, I think, 25 people sitting there to have the education. So that's growing fast and really, effective to do it in the waiting area, so you don't have to repeat yourself all the time. We also made posters, with we, I mean the volunteers, and we made a booklet for patients to take home with a lot of education, and also with information about them, so we can work closely together with the clinic, that the primary health clinic that they go to. Again, this is also in the waiting area. You see a pharmacist that is talking about medication. Just assume that no one is taking the correct kind of medication, or then the box is green and then the box is blue. It's all the same medication. They either take 2 of those tablets, or no, it's always a mess. So that's why there's education about the medication, and that patients need to bring the medication that they are using at home and tell me what they are actually doing with all those pills, and show me also how they inject insulin. And then, so this is what the pharmacist does this every week, and you can also see the dietitian talking. So that's also every week. But on special days, like when we invite children living with diabetes or young adults, we ask the OT or the physiotherapist to come as well for some entertainment in the waiting area. And the OT asked the children to draw what is important for them, and what they see in the future. Because a lot of children, they face a lot, like bullying at school, people thinking that they are bewitched, cursed, it's contagious, and they don't really open up to me at the beginning. But this was a really nice way for me to see what is important to them. The cornerstone of diabetes care is actually healthy food. Very important, and it's proven to be ineffective if a doctor says, like, no, you just need to eat less pap or ugali and a little bit more vegetables. It's really important to send those patients to a dietitian, and so they can guide the patient in how to eat more healthy. Then physical activity, we do promote it in the waiting area, and if people need more guidance in that, we have the physiotherapist. Then there are support groups in the waiting area, but also in the community, because it's actually all about support. Diabetes is a very difficult condition to live with. It's not just one pill a day or one injection a day. It's really a whole lifestyle change. And the complications are quite tough to live with. But if people can support each other, they don't feel lonely. And that's, I think, the most important thing. And that's also what we did for the kids. We brought them together. Some didn't know that there were other kids living with this. They don't have access to Facebook or TikTok or finding those people. And we were lucky that one of the game reserves around us invited the kids over for game drives and 2 night stay, so they can learn from each other and just have a lot of fun.
Nicole,
The
a question
name
from Hans, sorry to interrupt. He is
Yeah.
actually asking how affordable is healthy food in that area?
Yeah, good question. It's, I think, more about portion control. I think you can, they eat a lot of pap or ugali or nzima, all those, yeah, and they really have to do half of that. And if they have a little bit of money, they buy a lot of meat, and then if they have a little bit more understanding, they add some vegetables. So that's why it is important for the dietitian and a local dietitian to know what you can,
Alternatives.
yeah, what you can advise a patient. And there are other tricks to like reheat pap. Then you have less carbs in the pap as well. So those tricks are for free. But indeed, you shouldn't Google a diabetes healthy diet, because then you get the fancy Western diet. But it is definitely possible. But we also have the other way around, that patients don't have enough food at all, especially type 1 patients, or maybe even type 5 diabetes patients, which is malnourishment diabetes. They sometimes don't, or we hear often that people don't have enough food and then they can't inject insulin. And yeah, then you have poor glycemic control. It's difficult. And I don't
Thank
really
you.
have a solution for that. The name of the clinic is not Diabetes Clinic, even though I say it all the time. There's a huge stigma on diabetes. So we can't really call it Diabetes Clinic. And now it's called Futomi Clinic, and it means hope in Shangaan, in the local language. And that is what we want to share with the patients, that there is hope of a healthy life if you control your diabetes well, which is hard, but we are there to support. And I think that is the biggest cornerstone of the diabetes care. This is a picture of the kids camp. It was a lot of fun, a lot of support. And this is one of our patients. He lives with diabetes for already 17 years, and he creates a lot of awareness. He's almost proud to have diabetes, and he shares it with everyone. He's breaking the stigma, and he leads a lot of initiatives. So he did this awareness walk in World Diabetes Day. He has support groups. And he speaks on radio. He has now a fundraiser to fundraise for glucometers. He always gives his own glucometer to other patients in need, because he can feel the hypos and the hypers, so he knows what to do. So very inspiring patient, and I think that's really important, to find a patient that is well controlled and wants to help other patients. Then some stats from the clinic. It was opened in June last year, and stats from last month. So we had 347 visits, 260 no-shows. We did improve that by phoning patients to come to the diabetes clinic. They got lost in the hospital because we didn't have a dedicated space. People don't know where the diabetes clinic is, or Futomi clinic. So we're trying to improve that. 4 no-shows because they passed away. From 26 people, I don't know if they actually came because of poor data collection. in those 347 visits, we have helped 152 patients. So that's an average of 2 visits per patient. But it's also included a few visits from patients that will come next month. So I think it's a bit higher. I think around 3 visits per patient. And so far we are helping 12 children with type 1 diabetes, and I excluded that in the statistics. So 43 patients had a pre and a post HbA1c that I could find in the system. So on average, the pre-HbA1c was 12.4%, ranging from 5% to 22%. And the HbA1c says like 12% is around an average of a glucose of 16. So for the last 3 months, they had an average glucose of 16, way too high, and that's causing damage. Post, the clinic visits, it's 10%, which is still not the goal. The goal is lower than 8%. But yeah, there are reasons for that, why we don't achieve that. And it's also included a few patients that we are still helping. But it is a 2.4% reduction. And that really means there is so much less chance of death, heart attacks, and complications like amputations of legs and hospitalization. And I didn't really realize that how much it helps. So that's the left slide is not the best picture, but every 1% in reduction of HbA1c is 21% less diabetes-related deaths, and especially the amputation, 43% is a huge, risk reduction for those patients.
Nicole, those people who died, those 4, are they did they die due to diabetes or a complication from diabetes?
Yeah, from
related?
3 of them, I don't know exactly what they died of, but 3 of them I know. I already had the conversation. I don't really call it palliative care, but I guess I should call it that. I told them, your kidneys are not functioning well. You have a huge risk of dying from a heart attack or getting a stroke. We will try to stabilize it, but it is actually, these patients are just there, either already living with diabetes for many, many years, or they ignored the diagnosis for a long time.
Yeah.
So out of the 43 patients that I could track in our system, only 10%, 10 patients met their treatment goal, so lower than 8%. And there are just not a lot of HbA1cs that I could find in the system. And it also doesn't say a lot because we actually discharge patients when they are well controlled for us. Some patients we can't go lower than 10% because we can't give glucometers. They have hypo, so we can't go higher with insulin. So for some people, it's just acceptance. Other patients that are well controlled, according to their glucose diary, we discharge to PHC, to the primary health clinic, and they will follow up the HbA1c, but they use a different system, so I can't track that. So probably patients that are well controlled with a HbA1c of 8%, they are not in these statistics. We take care of a lot of complicated patients with renal impairment, blindness, socioeconomic issues like a lack of food. So then you can't go below 8%. We also take care of newly diagnosed patients. They come in with an unmeasurable HbA1c, and then it's actually quite kind of easy to get them to 5 or 6%. So again, it's a bit of a mix of, that's why the HbA1c doesn't say a lot. Also, for a long time, we couldn't have HbA1c because the lab was hacked and we couldn't use the lab for 3 months. And then, I have a big fear of hypoglycemia. That's something that kills today. And hyperglycemia, you can live with that for a bit longer. So sometimes I also don't dare to go too low, especially older people or people that live alone. And most of the statistics are from 2024, and that was a very different setup. So yeah, these stats don't say much, but at least we have helped a few patients. And that's actually if you ask the patients, why are you now suddenly well controlled? They always tell how they felt the support from the clinic. And yeah, this is a long slide, so you don't have to read it. There are blogs about it on our website. But people really live for 10 years with diabetes. They go to the doctor, they repeat scripts, and nobody tells them what diabetes is. So the education is the biggest part, and the support that they feel from patients sitting in the same waiting area and our patient ambassador. So I think that's why I do it, not for the numbers, but for the patient stories. Then for the future, creating a lot of awareness about diabetes, that it is something that you can live with if you accept the diagnosis and you get treatment early. I really hope for more screening, and I will advocate. I'm not a politician, but I will advocate for more strips. At the moment, we do it via fundraising and donations, but I want the province to step up. But we will do a lot of education in the other 16 clinics, more teaching days, and I hope in the future we get a daily diabetes clinic in the hospital-led. So I'm the doctor at the moment, but we are looking for a new doctor. And like with the Let's clinic, I handed that over to the hospital, and now it's run by the Obs and Gynae team, and that's what I want. That if I leave, Tinswale Hospital, that it is run by local people. That QR code is not working. Thanks for listening.
Wow, thank you so much, Nicole, for this wonderful presentation about your project. I think you have elaborated like a lot on the plus and pros of this story, and also the hurdles you need to take, which are quite a lot, if I hear it like that. We have some nice questions already in the chat, so I will give them to you. The first one is from Victoria, and she's asking, are you working with a certain framework or guidelines for your cooperation with the traditional healers? And how did you approach this collaboration?
Good question. No, we don't really have a framework. It's a very interactive session. So what they want to know about diabetes it's a very basic or zero knowledge. But some like traditional healers actually come to the diabetes clinic as patients. And we are working with the traditional healer association. And we find those people because we are working with nurse assistants, actually unemployed nurse assistants. There are many here in this community, and they want to volunteer as well for the hospital, for Tsemba. So that's pretty much our way into this community, to understanding the community. And with that, we also give the nurse assistants an opportunity to improve their CV and find a job. So that's also why we lost the first nurse assistant that was part of the diabetes team. She got a full-time job, and that's exactly what we want. And now we have another one. They all volunteer for us.
Nice. Sorry, can I have a question on this area? Do you have any idea about the local practice or the myth about diabetes? Have you do any small research on this? It's very important when you run a clinic in a rural area like yours.
You mean the local practice for the traditional healers?
No, for the population in general, how they perceive their diabetes.
They perceive it like a death sentence. That's why people ignore it until it's too late. And that's, I think, why awareness is very important, and having patients like Exoda sharing that you can live long and healthy if you control your diabetes well.
So any practice, local practice, people that are practicing something or taking some leaves or some roots. Or
Yeah, they go to the traditional healer and they give a lot of concussions, or they do cuttings and stuff like that. So that's why we also go to the traditional healers. Like I don't say to the traditional healer, you can't do anything. And if they do cuttings, I'm okay with it, as long as you don't put stuff in those wounds. And if they give patients their herbal tea, that doesn't contain a lot of sugar and things that are causing damage to the kidneys. But I do believe that you can't ignore the traditional healers. You have to work together with them.
It's very important, very important. And I see from my experience, a lot of patients, they came with gangrene, foot gangrene from cuts, from a lot of putting some special or whatever, and they come to hospital for amputation. That's my experience.
Yeah, no, definitely. Yeah, so it's, even though we can't do a lot like special shoes for diabetes patients, a lot of promotion, like take care of your wound.
Very important.
Yeah,
very important. Yeah.
Prevention.
Can I ask a question about this? So, what if you tell the patients about these cuts and how damaging they can be? Do they believe it, or do they always believe the traditional healers above you guys?
Well, we have a selected patient population because they do come to the diabetes clinic. But it's even in our diabetes booklet. Just tell the diabetes team that you use the traditional healer so we can guide each other. And it's also a lot of psychological support. And that's why we need the traditional healers. They have so much more time to talk to those patients and guide them. And it's something, we just started doing it. I mean, we have done, I think, 10 trainings for 20 traditional healers. So that seems like 200 traditional healers, but there are 2,000 traditional healers in this village. So, and we have like 30 doctors. So I do understand that patients go to the traditional healer.
Do the traditional healers ask for money as well, or something else in return? Oh yeah, of course. Okay.
Yeah. No, of course. And that's why they wouldn't say, like, stop going to me, I can't do anything for diabetes, go to the hospital. No, they will say, I can help you as well, you have to drink this tea. And one traditional healer, she's a patient of me, she's been to the clinic 4 times, and she does just say, no, I give this to my patients, and they are cured from diabetes. And I do challenge her, like, why do you not take it yourself then, if you can cure yourself? Then no, I don't dare to. So then in the end, she did take her own treatment, and it didn't work. But I know that she will still sell it to other patients.
It's her income, right?
Yeah, exactly. Yeah. But I think there's already a lot of shame in the hospital, like doctors saying, like, you can't use traditional healers. So that's why I promote more now. We have to work together with them and try to understand how we can collaborate.
Yeah, I think that's really wonderful, because I think there's a very delicate balance between traditional healers and primary secondary care, and very context dependent, because I hear in your story that the traditional healers are quite open and willing to think along. In my experience in somewhere northwest of Ghana, that's not the case. Not getting there. So that's a very difficult other area of expertise to get into with them. Yeah.
No, definitely. And we at the moment only target the ones that are are part of the Traditional Healer Association, and they are also open for HIV testing. They are actually trained in HIV testing. So it is a selected part of the traditional healers that I train.
You also told that some traditional healers you give like education to about diabetes and how to treat it. Did you ever ask to get an education in traditional healing to just, give the same kind of respect and also to learn what they are doing? Did you ever do that?
Yeah, no, definitely. It's a two-way stream. So I asked them what they will do. They showed me the concussion. They showed me the bones that they throw, and then they can see if a patient has TB or diabetes. I mean, I don't say in their face that I don't believe in that. And I see where they do harm. I will change that. But if they don't do harm, then yeah. And I also believe, I mean, we do see patients here with kidney failure because of concussion from the traditional healers, but I think the other way around is the same. We give antibiotics that can harm you, or medication that can harm you as well. Yeah.
Mhm. Yeah, I think that's a nice perspective on traditional healers. We have another question, and I think that's a very interesting one as well. How do you arrange funding for this project, and how do you make it sustainable or long-term funding?
Sustainable. Yeah, sustainable is if you do fundraising, it's not really sustainable. Yeah, at the moment we do fundraising. That's the easy question and easy answer. And I've asked actually the volunteers to do fundraising, and they come from the UK or from New Zealand, so they are happy to share some money. And actually, it is Exoda, so the patient living with diabetes, that is driving this. He asked me to help, and I'm not a fundraiser. But we just tried some things, and now the ball is rolling. So the biggest radio station from South Africa got to know the story. I don't even know how. Oh no, yeah, the volunteer actually just wrote to the radio station, and so I did a radio interview for 4.5 million people, and they donated 2,500 euros. So yeah, not sustainable. I'm not going on the radio every month, but yeah, those things, and it's a lot of fun. We did a 35K fundraiser walk, but it's for me, it's more about the awareness, why we walk for diabetes. But sustainable is me going to the province and say you have to buy glucose strips. And
Yeah.
I think actually the whole project I started with like what is locally available. And a year ago, we still had HbA1c via the lab. We had glucometers, we had strips available. But yeah, at the moment we don't have that. And even today, like there are no syringes anymore for the insulin. So it's only getting worse. So how to really make it sustainable if the situation is changing so rapidly, it's difficult.
Maybe it's also a bit more on the long term since you just started and now getting your statistics, and like when you really have something, then you can go to the MOH and say like, listen, this project really works, and
Yeah,
we need to
no,
move
definitely.
the audience and
Yeah.
people. Well,
And
it's
then I
not
have to do a little bit better data collection, and that's not really
yeah.
my passion. But if maybe one of the doctors here wants to come and volunteer here and do some data collection, feel free. Come.
Well, that's a nice invitation. So jump on, I would say.
Sorry, Nicole, can I help a little bit on how I was doing my clinic inside the government in Maputo? You can go on those pharmaceutical or these the fabricant of the strips and ask for the strip that are almost expiring. Yeah, you can get some couple, but it can help you if you don't have. It's better than you don't have nothing.
Yeah,
To
no, definitely.
propose your
So that's
patients. Yeah.
what we do as well.
Okay,
But
that is
it's
good.
a whole world of glucometers and strips, and they don't fit on the same machine.
Yeah,
And
exactly.
so we have like a bunch of glucometers here where we don't
Yeah,
have strips for, and
yeah.
that is.
That's what I used to do in Maputo. So I used to have a lot in my cabinet.
Yeah.
Okay,
No.
good. Mm-hmm.
All right. We have one more question, and that's you were talking about type 5 diabetes.
Mm.
The question is, can you elaborate a bit on that? What is it?
Yeah, not really. It's something not new. It's already known for, I think, 20, 30 years that there is malnourishment diabetes. And now, I think 2 or 3 months ago, the WHO acknowledged that there is a different type of diabetes. And I think it has something to do that the pancreas is not working because of malnourishment. And that can either happen in childhood, so your pancreas is not developing well and not producing a lot of insulin, and that's why you have diabetes. Or it can even happen if you malnourished now because you don't have food, that your pancreas stops working and you don't produce insulin. But if this is wrong, sorry for that, but Google it, and then it's difficult. There's no test to see. You can go into the history or patients that are malnourished. But that's another thing. Yeah, how do you help patients that are malnourished? I think we all battle with that in the hospitals that we are working in.
Definitely. I think Han is also adding to you that long-term malnutrition is compromising the pancreas function and it exhausts the pancreas. So he supports what you're saying.